well, and it emerged out of lots of conversations we were having with patients at the time. And it also emerged, I want to sort of preempt here, out of the idea of Wordle, right? I don't know if you play Wordle, but it's been a quite addictive word game that people play, where they get a daily little quiz that looks a little, these sort of colours, where they try to work out what a word is. They can try and do it in 6 guesses, and they're getting little clues along the way, getting a real positive reward every day. It's a new single thing. It's just one of them a day. You can do it. You share it with people. And we thought, this seems to be getting people to do something, feel positive, build social connection. Can we use some of those theories in this? And we ended up publishing a paper about using LLMs to replace therapists, with my colleague Simon Williamson, who's been involved all the way through this at Imperial. But that, this was just a sort of little thing we were playing with, and it didn't quite work out. We did a lot of work with patients and professionals at these 4 trusts in the West Midlands, and settled on a slightly clearer sort of questions around how can we increase the number of people completing their talking therapies, and how can we maximize the benefit of that through provision, some sort of waiting well early support that could be digital. And I did want to link this to sort of a behaviour change approach around capability, opportunity, motivation, the COM-B model, where we might think about, are there more things than just giving people like a little bit of information about CBT? How do we build up their views, their ability to attend a little bit more widely, the opportunities together, and how can we really motivate people to do it? And through that this sort of process, we decided to do a Delphi study to understand what we could support people with prior to beginning CBT. So the question we set out with was, what should be in what should people know before they start NHS Talking Therapies? And we recruited 41 therapists, asking them to, as long as they've got 3 years of experience in NHS Talking Therapies or a leadership role at the moment, from across 7 different NHS trusts. And we did 3 rounds, of which we had pretty good retention. And you can see the participants that we had, which are broadly representative of the NHS Talking Therapies workforce, although we really underrepresented Black people, disappointingly, but otherwise we had a reasonably good spread, and thought we had a reliable starting point for this study. And what emerged from this was these 6 topics to build a consensus curriculum of what people should know before starting CBT through NHS Talking Therapies. And so it started with emergency information items, then a couple of items about what is CBT and what can it be for, then some practical questions about what do you have to actually do to prepare for CBT, what's the best way to get ready for it, what does it actually look like when you're in there, what is it not the same as, and what sort of things can you do now to get the most out of it. And these all reached our consensus criteria of 80% agreement. And we finally, and so this is kind of under review at the moment at BMJ Open. Now, so having established this consensus curriculum and having this sort of broad idea that there's a place for technology in helping people prepare for therapy, we returned to this EAST framework, and this is, the principles underpinning the sort of Wordle approach that I was talking about before. We wanted to make sure that we were making it easy for people to do whatever it was that we were asking them to do to get this information. We wanted to make sure it was a really timely thing that was either not taking a huge amount of time up for people, but was also sort of predictable and being given at the time when they needed to know it. We wanted to think about social aspects to it. How could we help people think about this in a relational way rather than a information giving professional sort of way? And finally, we wanted to make it fun and attractive. And I think those are kind of useful principles. Then through our conversations with the trusts, we talked about when is the best time in terms of this timeliness to give the information. And essentially, it seems like the best thing is after people have been referred in for CBT therapy, we'd like to, they'll get assessed and at some point judged to be appropriate for CBT. But there are other pathways they might go down, like IPT or other sorts of therapy they might be referred for. But once we know that they should be getting CBT, we can, which is the vast majority, we could then give them information about what that involves. So after that appointment, they could then be delivered digital information. The impression was actually it's really important to think about their heterogeneity of different learners in particular. And so and this was particular feedback that we got from neurodiverse people, that having offers of daily videos and audio options and text reading options, things people could come back to in certain colours and colour schemes as well, would be really important to consider if we were going to try and give people information in a usable, easy to access way that would engage them and give them something to build them up. And we wanted to make sure it would cover the curriculum that we've established. And then they could do all that prior to then starting their CBT therapy, at which point they'd be able to, they'd be better set up and hopefully more motivated and inspired. And so we came up with this idea of basically building a digital patient information leaflet. Although I like to think of it as a digital patient inspiration leaflet, because it's not a neutral information giving thing. It's about saying, you can improvement, recovery is possible, and take some steps to move towards that, which I suppose is a CBT ethos in a way. But as you can see, what that looks like is this app called Every Step, where each day people are getting this video, audio and words option to discover a little bit of info. They'll get these sort of really simple bits of information giving. You can see at the bottom there's a sort of support option for people in crisis, addressing some other curriculum items. And then they're getting either these sort of mini podcast audio informations, hearing a conversation about CBT, or they're getting a little video, which could be a confessional testimonial or a sort of more corporate style bit of information. And then they could also look at these sort of word sections, which can mirror an Instagram story that's just some really simple sentences explaining bits of information. And having built that app, actually, we've been sort of populating it with this content, which has been built in this way. This is a paper that's under review at Journal of Medical. It's been accepted with minor revisions at JMIR Formative Research. And that involves, we sort of brought together a creative team who could make all these different creative components, along with the expert contributors from the trusts, and manage them through a project management sort of setup in the middle, in order to continuously validate what we were producing, make sure that the content was matching up with the expectations of therapists, and this way we sort of managed to create a nice range of content, which at the end 80% of the NHS Talking Therapists we interviewed said that the resources would help them. That's an informal result. I wanted to show you what a sort of confessional video would look like. So here's a character who that was sort of constructed through that process, and who shares a little bit about the goals item, which is one of the items in the consensus curriculum.
If you could wave a magic wand and change something about your mental health, what would it be? Well, I haven't got a magic wand and there's no quick fixes, but that's kind of an interesting question that my therapist came up with on one of my early sessions. And I just said, I want to feel better, I want to be happy, be energetic, be more confident. So we talked about all those things and what they really meant to me. Because, I'd become withdrawn, I didn't see my friends, I wasn't feeling connected to my family. But my therapist turned it around and got me to imagine a day when I was better. It'd be like. Well, I realised that I'd be up on a Saturday morning watching my son play football, there with all the other dads, and I hadn't done that for months. I couldn't really face seeing them. I was rarely awake before midday, and even if I was, to be honest, I wasn't a whole lot of fun. So we agreed that this would be one of my therapy goals, to be at one of my son's games before the end of the season, which was in May. I'm not going to tell you it was all plain sailing from there, but with one thing and another, by the end of the season, I still wasn't ready. But every therapy session I went to, I knew what I was aiming for. Sometimes I almost gave up, but I had a goal. So in fact, it was the August bank holiday when I finally got to see my son kick off the pre-season friendly. Even I could see how much progress I'd made. And my therapist could definitely see it. And my son, he could see it too.
There's a range of videos a little bit like this. I'll just show you a very brief view of a sort of slightly different style as well for different sorts of learning.
Today, cognitive behavioral therapy is used all over the world to help people with their mental health. It has been shown to be effective in over 2,000 clinical trials.
So as you can see, totally different sort of style, different sort of learners, and basically this is what emerged from having a range of different creatives working with a range of different professionals. And we then also ended up with these sort of visual reading words sort of contents, with little quiz questions in them, which are a much more low-key way of receiving the information that we're trying to give. But again, short, simple information that you might be interested in if you were to address some of the questions on the consensus. So really that brings us up to the present. We've got this sort of app with this content that we're currently studying. So we've got some data from patients and staff. They think it's positive. We've got a lot of PPI and requests from trusts to trial this and give it a go. And we've also got sort of experience of implementing apps as well. So feel pretty ready to begin with the feasibility study, which will be which the ethics is going through for at the moment, which is going to sort of follow into a small randomized controlled trial against treatment as usual. That's exploring the engagement outcomes of this. But I want to talk about the next steps about this, which is really where we've been really lucky to be supported by the 3 schools, because we want to think about, well, is it possible to actually address specific concerns and have a targeted impact? I think NHS Talking Therapies is this really, really interesting thing that with 1.8 million people, it's sort of mind-bogglingly vast, reaching into all sorts of corners of society. And I guess probably all of you know people who've been on NHS Talking Therapies, and many of us will have ourselves. But what about, and so we've made this sort of heterogeneous, generic app, but is it possible to target people who are particularly vulnerable to disengagement? And this is where we realized that people whose religion is Islam have a much lower completion rate of therapy than people who have no religion or who have Christian faith. And we wondered whether we could explore that. And I think that it's worth just considering a few different explanations for that we've been bouncing around. I mean, one is culture. Some people will say, oh, there's a stigma about mental health. That perhaps is a slightly old-fashioned view. Another view is that actually people perhaps are benefiting from alternative support, and if they have a close knit faith community, they may be less likely to need support and may feel that maybe a genuine case of those people who actually self-refer and then don't need therapy later. So hard to pick those apart. Likewise, is it possible that this is actually driven by low SES? As you can see in this chart here, recovery rates, which isn't the same as engagement, but it's lower among Bangladeshi and Pakistani people in particular compared with many other groups, which may be linked to low SES among on aggregate among Bangladeshi and Pakistani people. It could also be linked to age, given that younger people are less engaged with NHS Talking Therapies, and it could be more linked to more amorphous sort of health beliefs about what works and what doesn't work. So we considered different approaches, and we thought really hard about this, and I think this is where it starts to get, well, we've really had to sort of work this through quite, it's quite difficult, but if we wanted to improve the outcomes for people with Muslim faith, we might think about distinct therapy approaches, and people have been studying that. We might think about focusing on religion concordant therapists. We know that concordance between therapists and patients can improve outcomes from some research. But we could also be thinking about cultural sensitivity training. How can we make the whole thing work better for people from faith minorities? Or we could think about targeted digital information, and you'll not be surprised that's the sort of approach that I favour, and I'm just going to justify that, which is because it's so much more low cost than training people. This is a thing that could be produced and offered quite cheaply. It's also can be made universally available, and that's really important because with something like distinct therapy approaches or religion concordant therapists, that's all very well in sort of in perhaps big cities. I work in Nuneaton in Warwickshire, where there's a really small Muslim community, and it's just unlikely that they're going to be able to access this sort of thing. So actually, there does need to be a universal offer for people who may not live within a large area that's especially diverse. Likewise, we've touched on the possibility that low engagement may not be driven 100% by faith-based problems with therapy. It could be that this is to do with the SES issues that I talked about. There's all sorts of stuff that could be going on. It could be an artifact in the data. We need to really understand the problems before leaping to what the solution, what exact information people might need. I think the other cool thing about digital information is that it's quick to produce, can be delivered short, in the short term, can be made available to people, whereas training a lot of people just takes a long time. I'm not sure we can wait to try things. And I did just want to address one objection that comes up often, which is around digital exclusion. Interesting. I raise it because I think we were surprised to find this. The ONS data shows that Pakistani and Bangladeshi people are less likely to be digitally excluded in terms of access to the internet than white British people. So, to be sure, this is a problem that's worth considering across society. It doesn't rule out using this to approach the sort of particular problem that we're interested in. So I'm sort of coming into land with my presentation here, but here's what we're going to be doing in our 3 schools funded project that we're working on. So we're going to be doing workshops where we explore the experience of people of Muslim faith with NHS Talking Therapies, particularly around disengagement. And those will be online, and they'll be at University of Warwick. And once we understand those barriers, we'll be able to work to develop multimedia content, which will be able to, in the styles that you've sort of seen already, to try and address those concerns, address those barriers, see what we can do to mitigate those, to build people's confidence around NHS Talking Therapies, and to sort of co-produce that content together, before then closing the loop on this process by doing a Delphi study to ensure that that the resources that we've made are meet the concerns that have been raised, and also are accurate as well. And with or without further changes that are required from that, we'll have resources which can then be just delivered through this app that we've built already. So that gives us a quick route to sharing it. And I guess that the way that gets the sort of follow-up step to that is as simple as this. So it's this pathway again where they get referred, they get assessed for as benefiting from CBT, and then they can just download the Every Step app at that point, access all this content being gradually delivered to them in a mode that they find useful before then beginning therapy. And this is all sort of designed to be embedded relatively easily within the NHS in a sort of quite straightforward implementation. So that's the sort of big picture there of what we're doing. And I think that's the end of my presentation, but I'm just really hoping we can have a few minutes to talk it through. So thanks so much for joining me, and I look forward to hearing your thoughts on it. Also, please do feel free to drop me an email at nathan.hodson@warwick.ac.uk. I'm not much of a question asker in these things, but do shoot me an email instead if you're like me. But happy to talk it all through now.
Brilliant. Thank you so much, Nathan. That was really interesting. I'm sure everybody will agree. I particularly like the Wordle approach you mentioned. So we've got a question already. Imran, I think that's it. You may be on mute. There we go.
Yeah, I'm off mute. Can you hear me okay?
Yeah, sure can.
Hi, Nathan. Thank you for the talk, and the app looks great. I'm actually I'm also a recipient of the mental health 3 Schools Mental Health Award, and I'm actually also looking at addressing some of the barriers in engagement for British Muslims, specifically in the area that I'm at in East London, in Tower Hamlets, which is the largest city. So I definitely want to keep in touch with you, Nathan. And that'd be great. Yeah, so I'm out of those stages that you're working on. I'm sort of more of trying to attempt the adaptive approaches, or incorporating faith into therapy.
Yeah.
So which kind of leads me to one of my questions is about the app, and I'm sure you've thought about this, but in terms of if you come across, and certainly sort of reading up about some of the literature and my sort of an experience that I found with barriers in engagement with therapy, around the therapy itself, whether it's able to allow individuals to bring their whole selves to therapy. I wonder if you encounter a barrier such as that. So fundamentally, they may have a problem with the CBT itself. Something along those lines of how are they going to incorporate how are they going to be reassured to bring their whole selves to therapy? Would the app be able to prepare them for that, or what's sort of your thoughts around that?
Yeah, I mean, I'm just interested in what. So, are you saying that you think it could? I just think this is absolutely fascinating. So, I'm really grateful to be able to benefit from having you here. Why is there a specific thing that you think people might not? Is it that I'm trying to get my head around? Is this a perceptual problem, or is this you think it's a sort of real problem? Is this the first question I just wanted to clarify? Is it that you think people genuinely can't?
Yeah,
use CBT?
Well, no, I think I mean, it's something that I'm trying to get to understand myself as well, Nathan. So I'm not quite there yet as well, but from what I know, certainly one of the barriers is around being able to bring their whole selves to therapy. So worried that you're not able to talk about specifics within the religion. What demonic whisperings, for example, addressing the nature of the soul. These things are a part of the identity of many British Muslims, or who identify as Muslims. Is the therapy able to work with that? That's something that has been reported. Again, it's very messy. Like you said, it could be specifically things with culture and religion or socioeconomic reasons, but certainly it's something around that targets beliefs, and incorporating those into therapy is something that's not been looked at.
No, sorry, thanks for bearing with me there to clarify, because so it's the perception that there could be very real beliefs that people have, which they feel just wouldn't be understood, wouldn't be by a therapist, and perhaps would be somehow in tension with the therapeutic approach. I can see Domenico's got his hand up. Do you want to jump in, or do you want me to?
Oh yeah. No, you go ahead, and then
my view on that is, absolutely, this is exactly the sort of thing that we'd like to try and address with with this sort of content that can provide just really simple information saying, you can explain this stuff to your therapist. They'll be expecting to be culturally sensitive in their approach to things, but also not in such a didactic way, but in trying to seek out examples of times that this has worked well that we can share, in order to sort of build confidence in the professionalism of the NHS Talking Therapy workforce. At its best, I guess, would be the approach. I suppose I don't want to prejudge what we're going to identify, but if that were the sort of thing we identify, that would be the approach. Does that answer your question?
Yeah, it does. It does. I think so. But it would be great if we can keep in touch, and
yes,
and we can sort of discuss more offline as well.
That would be great. Yeah, thank you for raising this. And Domenico, did you want to jump in?
I think there's a wider problem there in terms of the approaches we provide within services can be culturally sensitive and understand really the different background. I mean, this app will be implemented not in a vacuum, but in other kind of initiatives that are happening in services. And Imran, you probably be kind of your project instrumental to others in terms of how we expand kind of the understanding from professionals as well. And I think the two things have to go arm in arm, like in terms of the service user have a right to understand more about the therapies that they kind of are offered. And on the other hand, the professional have a duty to adapt the therapies that they offer to service users. So I guess like this app will be a part of kind of fulfilling the rights of service users to understand more about the therapies, but it will not necessarily have a role in changing the therapies, which other approaches would do. And I mean, when we did the study recently with East London, and I'm actually used to work there, and we collaborate very closely still, which was called the Ariadne study, where we look at different minority ethnic groups. The idea of diversification of therapies was also really important. So there's not one size fits all, but again, the approach of providing information, what people kind of agree to do, and providing a bit more information before they fully attend the therapy to increase engagement is something that is an agnostic principle. It could work with different types of therapies. CBT is certainly one of them, but in theory, this approach could go across different types of approaches that people find are helpful.
Yeah, that's true. Yeah, I've been going on about CBT because that's where we've been focusing on, but it would be interesting to look a bit more widely. Yeah.
I've got another question. Have you considered extending every step to GP referrals or potentially after session 2 of therapy?
Yeah, and that's something that I think is definitely worth thinking about, because at the moment, like I said, it's very CBT focused, but there are other general bits of information that we could give earlier, and there's definitely a significant dropout during that first, before the assessment for, what type of therapy is appropriate. People are disengaging, so it'll be really interesting to try and provide a bit of reassurance earlier on about where people are in the pathway. Yeah, thanks.
Has anybody else got any further questions at all? No, I think we're done. I think you've stunned everybody into silence. So thank you so much for leading that seminar. It was extremely useful, and we will upload a copy of the recording onto our website in due course. But apart from that, I thank you very much.
Brilliant. Thank you.